Good evening, everybody. Today we are going to discuss about the general anesthesia management in COVID pandemic. Yes, I am sharing the screen. Yes, general anesthesia in COVID pandemic. I am going to discuss about the universal precaution which we are going to take during anesthesia. I am going to discuss about the regional anesthesia also some point. Why this topic is very important in the for anesthesia point of view, because the elective procedure, because there is a risk of transmission of coronavirus in aerosol generating procedures like a tracheal intubation and extubation, non-invasive ventilation, high flow nasal oxygen, bronchial suction, bronchoscopy, oral suction. Anesthesiologist is always there in close proximity to the upper respiratory tract. Therefore, anesthesiologist personal protection should be on priority. Now, come to the selection of the patient. Elective procedures should not be performed in the patient who are symptomatic with COVID-19, who are suspected of having COVID-19, who are likely to be still shedding virus after COVID infection. In such patient, discuss with surgeon about the urgency of the surgery and delay if possible. There is a high rate because there is a high rate of perioperative morbidity and mortality in this patient. Also, they place the operating staff at risk for the infection during the aerosol generated procedures. Now, come to the pre-anesthesia checkup. I am going to discuss about the extra workup, which we do not work routinely. There is institutional routine protocols for the preoperative evaluation and lab testing should be followed properly. All patients who are scheduled for surgery should be screened for exposure of COVID-19. Screen for the symptoms like fever, cough, shortness of breath, muscle pain, sore throat, loss of taste and smell within the prior 2 weeks. The patient with above symptoms should be referred for the further evaluation. Some institutions are routinely performing COVID-19 testing before scheduling the elective surgery. In pre-anesthetic evaluation, one should focus on the epidemiological history, travel or contact history, symptoms of COVID-19, occupational exposure, systemic comorbidities, drug history, especially on immunosuppressant, airway examination, oxygen saturation on room air, and temperature recording is must. In investigation, in symptomatic patient, go for RT-PCR. Routine test should be done with X-ray chest. Focus on WBC count in hemogram. Go for C-reactive protein, LDH, RFT, LFT. Cardiac evaluation is must. Serum ferritin level, and when patient is symptomatic but RT-PCR is negative, then go for HRCT thorax, which shows multilobular ground glass appearance, especially in peripheral area and the lower bilateral lower lobes. Now, one additional consent should be taken from the patient, which is mentioned that I will not hold the hospital or treating team of doctor and staff accountable if appropriate testing reveals that I or my accompanying family person turned COVID-19 positive at any period of the time during my stay in the hospital. We are regularly taking this consent right now. Now, come to the OT setup. Ideally, guidelines says that the negative pressure ventilation OT is required with closed doors for the COVID OT. But the new guidelines suggest that if the air exchange cycle, there are 25 air exchange cycles per hour are there, then we can work in positive pressure OT also. Now, for this COVID pandemic era, preparation of the OT before the patient should take in operation theater, clear out all unnecessary equipments from the operation theater, There should be one dedicated tray and clinical waste bin in changing room and operation theater. COVID alert sign on every entrance of the theater. Prepare COVID-19 airway trolley. I am going to discuss about this COVID-19 airway trolley in next slides. Prepare video laryngoscope in separate tray. Prepare all anesthetic drug and emergency drug which we are required for the particular surgery or anesthesia. Prepare anesthesia machine ready to use. Keep all setting ready. Use sterile plastic covers for monitor, ventilator, anesthesia machine and laryngoscope handle. Ensure that you are using a closed suction system to minimize aerosolization. There should be a visible checklist attached on the OT. OT walls or should be available in OT. Now, COVID airway trolley. This COVID airway trolley must consist of video laryngoscope and conventional laryngoscopes, one stellate boogie, tube ties, oropharyngeal airway, nasopharyngeal airway, lubricant jelly, appropriate size cup tube which is tested. Cup is tested properly. Igel or laryngeal mask airway of appropriate size, syringe for cup inflation, oral suction catheter, scalpel for emergency airway, nasogastric tube, heat and moisture exchange filters, ambu bag. This is our airway trolley. There is a video laryngoscope. We have conventional laryngoscope, two face masks, oropharyngeal airway and nasopharyngeal airway, one stellate, one boogie. We have IGL or LMA for rescue ventilation, syringe for cup inflation, viral filters, and ET tube. The cup should be tested priorly. Drug card for the intubation. Generally, there is no special drug required for a COVID patient. Glycopyrrolate plays the key role to restrict secretions of the patient. When patient is on antiviral, midazolam and fentanyl, there is an increase of plasma concentration. So use this drug very cautiously. Other routine drug on trolley should include induction agent and muscle relaxants, reversal agent, and emergency drug required for that particular surgery. This is the anesthesia setup in our OT before patient in. There is all checklist we have in OT. Anesthesia machine ready to use. Drug trolley is ready. And airway trolley. Now, preparation of the anesthetic team. Prepare team member, assign their roles and setting out the airway plan before donning and entering the intubation room improves the safety and team effectiveness because the communication in full PPE is challenging and exhausting. Intubating team consists of one experienced intubator, that is experienced or senior anesthetist, one skilled assistant who can give required pressure or mask or help for mask holding, one team leader who act as a backup and administer drugs. Backup or emergency equipment should be kept immediately outside the OT and brought as and when required by an assistant, we call it as runner, who is wearing appropriate PPE and stand just outside the OT door. Always keep in mind that minimize the people in operation theater. Only 3 people are required for intubation team. Now, preparation of a changing room. In changing room, there should be one trolley with PPE kit, gloves, face shield, hand sanitizer, and N95 mask. All hand hygiene modalities. Donning and doffing sheet. In changing room, appropriate PPE consists of N95 mask with and respirator, goggle, eye protection, hood to cover neck and ears, face shield that covers the front and sides of the face, double gloves, water resistant gown, shoe covers, additional disposable head caps and beard cover should be worn so that anesthetist can avoid touching hair that may have been exposed to the droplets. Always keep in mind that enough time should be allotted for the fitting of PPE outside the operation theater. This is a small video for the preparation of the anesthetist and donning of the PPE. There are 5 steps. Perform hand hygiene, put on gown, put on mask or N95 respirator, put on eye protection, and finally put on gloves. Important to keep in mind that PPE should be done using proper technique and supervision. Same thing applied for the doffing of the PPE, even in the most emergency clinical circumstances. Even small lapse in the proper use of PPE increases the risk of transmission of infection to the anesthetist, particularly during emergency intubation and ACLS scenarios. Now, come to the preparation of the patient. Patient should wear a surgical mask during transport and at all the time. Patient should be transported directly to the procedure or operating room, bypassing the holding area or pre-induction area. Some institutions use a portable tent system with HEPA filter. For transporting the intubated patient, filter should be inserted between the self-inflating ambu bag and the patient at all the time. During transport, clinician or mama maushi who contact the patient should not touch the environmental surface. N95 mask protects the wearer from the outside. That is why N95 mask is essential for the staff and healthcare worker, and the surgical mask holds the droplets inside. Therefore, surgical mask is required for the patient at all the time. Now, technique of anesthesia. Regional anesthesia is not at all contraindicated in COVID patient. Instead, the regional anesthesia is preferred over general anesthesia, as the airway management and the associated risk of aerosolization can be avoided. I am not going to talk about regional anesthesia in detail today. The choice of anesthesia technique should be based on patient factor and the planned procedure. When we are giving to regional anesthesia, give the adequate dose of local anesthetic to avoid conversion into GA. First, test the adequacy of the local anesthetic, check the level, and then proceed for the incision. Many COVID-19 patients are on anticoagulant, which may affect the decision to use neuroaxial anesthesia or deep peripheral nerve block. Any technique do you use in anesthesia, don't forget to perform WHO surgical safety checklist, sign in and sign out protocols. Unplanned conversion from the regional anesthesia to general anesthesia should be avoided if at all possible. Patients who do not receive the general anesthesia should wear a surgical mask at all the time through the procedure. This is very important for the freelancing anesthesia practitioner, that the patient should be bring in the OT with the surgical mask on nose and mouth. If the supplemental oxygen is required in monitored anesthesia care or in regional anesthesia, the oxygen face mask, that is the plastic mask, should be placed over the surgical mask, or nasal prong with lowest possible flow can be placed under the surgical mask. Nasal prongs is a very effective technique, but the oxygen flow should be less than 6 liters per minute. Now, the popular technique, total intravenous anesthesia. Airway devices providing 6 liters per minute or more of oxygen are considered high flow, and their use should be discouraged if an airborne infection isolation room is not available as per the WHO guidelines. All airborne precaution, hand hygiene, and donning of personal protection equipment is recommended in TIVA and in regional anesthesia also. Early intubation should be considered in patients with deteriorating respiratory conditions. Supplemental oxygen can be provided with nasal prong, but a surgical mask should be worn over the patient face and nasal prong to reduce the droplet spread. Now come to the general anesthesia with intubation. General anesthesia with intubation is a high-risk procedure on high-risk patient in this COVID pandemic era, therefore required high level of precaution and expertise. Now come to the induction and intubation. One should minimize the number of people in operation room or intubation area. All the points I am highlighting here are very important points. Assistant to keep a distance of 2 meters from the patient. Standard ASA monitoring should be followed for all vitals. When you enter the OT, again check the anesthesia machine and required drug required for that particular patient. Check for working IV access. Pre-oxygenation should be done in optimal position for 5 minutes with fresh oxygen at 5 liters per minute. Use disposable airway equipments whenever possible. Rapid sequence induction and intubation is recommended in these patients to prevent aerosol spread of respiratory secretion. And most important, the most experienced anesthetist should perform the intubation in first attempt in this patient. No bag and mask is recommended in the COVID symptomatic patient or in COVID pandemic era. If required, in desaturated condition, the bag mask ventilation can be done with tight mask seal, that is a 2% technique with viral filters in place, and ventilation should be done with a small tidal volume and low pressure. Video laryngoscope is recommended because it increases the likelihood of first pass success and it allows anesthetist to remain away from the patient's oropharynx. As per my personal opinion, use whatever type of laryngoscope that you find most comfortable and which helps you to achieve intubation most rapidly. If you are going to use a conventional laryngoscope, use double gloves and remove the upper gloves just after the intubation. Avoid awake fiber optic intubation unless absolutely necessary, since there is higher risk of coughing and subsequent aerosol generation during the fiber optic intubation. Intubation should be performed under transparent plastic drape or intubation box kept on the patient. Endotracheal intubation is preferred over the supraglottic airway. If required, use only for the rescue ventilation. Supraglottic airway can be used for the rescue ventilation only, and if you are going to use supraglottic airway, use second generation airway, which allows you to intubate the patient through that airway. During the rapid sequence intubation, intubating dose of procuronium or the scoline should be given along with the propofol or ketamine. Intubate the patient after 60 to 90 seconds. It gives muscle relaxant enough time to work and to prevent coughing. Insert the endotracheal tube to ideal depth during the intubation only to avoid repeat disruption to the circuit and the cuff depletion. Inflate the endotracheal tube cuff immediately before ventilation start. Before you pump the bag, inflate the cuff of the endotracheal tube. Confirm the endotracheal tube placement by means of EtCO2 and bilateral chest expansion. Avoid auscultation. This is the small video of intubation demo.
Shall we run the intubation checklist? Can you confirm the patient positioning is optimal?
Yes.
Is our monitoring in place?
Yes.
Have we checked the circuit order including closed suction? Mask, closed suction, filter with capnography, circuit, and HEPA filter. Is the Yankauer suction connected?
Yes.
We can start pre-oxygenation with a two-handed seal.
Oxygen on.
Hot one, can you state the airway plan?
The airway plan is a rapid sequence induction with a video laryngoscopy, a preloaded ET tube with a bougie. If that fails, I will call the not hot to throw in the rescue bag with a supraglottic device. If the SGA fails, we will go to a two-handed bag technique. If we can't bag, we will go for a front of neck access.
Right. Hot two, do you have all the equipment for the plan?
Yes, I have all the airway equipment for the initial plan, excepting for the rescue bag.
Not one, have we got the rescue bag?
I have the rescue bag, it's ready to go.
Okay, let's confirm end tidal oxygen above 0.8.
Yes, confirmed.
Okay, may I have my RSI drugs? Thank you. All right, sir, you're going to go off to sleep now. We're going to take good care of you. Drugs are in. Patient's fasciculating. Oxygen off.
Oxygen is off. It's a grade 1 view. The tube is past the cords. Cup is inflated.
Oxygen on.
Oxygen on.
Right, let's ventilate.
Okay, closing APL, bagging.
Confirm we've got bilateral chest rise. And we have capnography.
Confirmed.
All right, let's ventilate.
Yeah.
Opening the APL, turning the ventilator on.
Right, let's secure the tube. Secure.
This is what we practice in our hospital. We are using a plastic tape over the patient face mask, one heat and exchange voice filter at the expiratory limb, another filter over the face mask, no bag mask ventilation during the intubation.
Yes, sir.
Once we achieve the complete action of neuromuscular blocking agent, we routinely use now video laryngoscope, which is easy to use, keep anesthetist away from the patient face, and achieve most of the time first pass success. Make sure your patient is completely paralyzed during intubation. Insert the boogie under vision and roll over the appropriate size endotracheal tube over the boogie. Now insert the endotracheal tube up to the adequate depth under vision during the intubation only to avoid the repeat cup inflation and deflation of the tube. After successful intubation, remove the video laryngoscope and hand it over to cleaner for cleaning. Apply the viral filter above the ET tube connector. Confirm the ET tube placement again by means of capnography. Now inflate the cuff before you start the ventilation or before you pump the bag.
Using high quality heat and moisture exchange filters, which is placed at the airway, and the second filter is placed on the expiratory limb of the breathing circuit. For critically ill COVID patient, if necessary, administer intravenous fluid or vasopressor before induction of the anesthesia, and consider using ketamine, etomidate, or the combination of ketamine or propofol for the induction instead of single propofol alone. Anticipate that critically ill patient with COVID-19 may become even more hypoxemic and hypotensive after induction and during intubation and may land up in cardiac arrest, so prepare yourself accordingly. For any circuit disconnect during the surgery, leave the viral filter on the endotracheal tube at all the time if possible. If the viral filter is not in place at the airway, for patients who are not breathing spontaneously, pause the ventilation for some time and clamp the endotracheal tube before you disconnect the circuit. Use a cloth suction system as necessary for tracheal suction or oral suction. This is a small video for the disconnection. Leave the viral filter on the endotracheal tube or clamp the ET tube before you disconnect the circuit. What about the surgeon? The surgeon can enter inside the operation theater after 15 to 30 minutes of intubation as per the institutional protocol, which is based on frequency of air exchange inside the operation theater. Now come to the maintenance of the anesthesia. Avoid unintentional circuit disconnection during the procedure. One should follow the lung protective ventilator strategies, that the tidal volume should be maintained at 5 to 6 ml per kg. Previously, we are maintaining at 8 ml per kg. In such patient, symptomatic patient or COVID positive patient, tidal volume should be maintained at 5 to 6 ml per kg. Increase respiratory rate to maintain minute ventilation. Peak airway pressure should be maintained below 30 mmFHg. Adequate intravascular volume should be given. Optimal preoperative analgesia should be maintained. Antiemetic prophylactically should be given. Avoid intraoperative anesthesia record documentation. This is what exactly opposite of the guideline which are previously taught to us, that intraoperative documentation is must, but during the COVID pandemic era, one should minimize the intraoperative anesthesia documentation. We can document all the anesthesia event after dropping the PPE kit. Plan everything for the smooth emergence and to minimize the cuffing. Now come to the tracheal extubation. Extubation is equally high risk for aerosolization of the respiratory secretion as like intubation. Therefore, all similar precautions should be followed. All efforts should be taken to prevent coughing. Administer prophylactic antiemetic. Adequate pain management. Keep in mind to minimize opioids for the post-op respiratory depression. Prophylaxis for the coughing before extubation, which includes IV lidocaine, low-dose opioid, dextrometamide. Non-anesthesia personnel should leave the room before extubation. Apply nasal prongs before extubation, but avoid high-flow oxygen. Some people recommend to place wet gauze or surgical mask over the patient's mouth and nose just prior to extubation if the patient starts to cough. Any airway devices must be removed carefully and treated as biohazard. Place all the used airway equipment into double zip-lock plastic bag. After extubation, place a surgical mask over the patient's airway. Apply a plastic mask for supplemental oxygen over the surgical mask or nasal prongs under the surgical mask. This is a small video of extubation demo.
We've reached the end of the case. We're going to extubate the patient deep if we can. We're going to try and limit coughing. Let's put a plastic sheet over the patient's head and neck to avoid droplet dispersal. Okay, can you suction the patient's airway for us, please? And Marita, if you could get the mask and the syringe to deflate the cuff ready.
Air suction.
Your mask and your syringe is ready.
I'm going to control this plastic sheeting. Okay, you can loosen the tube ties so long. Marita, you're going to disconnect the circuit and put the mask on for us when we're ready. Let's turn the ventilator off and the flows off.
Ventilator off, oxygen off.
Okay, I'll hold the sheet.
Okay, I've untied the ties. Deflated the cuff.
And straight with the mask on. That's it. Once the patient's breathing comfortably on the face mask, we'll take that off and go straight to the surgical mask. And we're going to remove this plastic carefully so as not to disperse the droplets.
Now come to the recovery. Patient should recover from the anesthesia in operation theater only and should be transported directly to an airborne infection isolation room, bypassing the PSCU unit. Close respiratory monitoring is must in this patient as there is a risk of ARDS. Cleaning of all equipment with antiviral disinfectant as per the infection committee protocol. Leave theater for at least 1 hour prior to cleaning. Therefore, recording of time is must. OT should be cleaned by cleaner wearing a PPE kit. Now, very important is the doffing of the PPE kit. First, you remove the first gloves. Care not to touch outside of the gloves. Remove the full suit, full gown, inside out, not to touch front of the gown. Now remove the eye protection or face visor. Face visor should be touched only headband. Remove second gloves. Remove mask at the end and untie the lower strap of the mask first. During the doffing, avoid touching to head and face. Hand sanitizer should be used after every step. Always keep in mind that mask on first and mask off last. Now, to summarize today's presentation, what we healthcare workers should do to optimize the success: preoperative assessment, including airway assessment; preoperative team briefing to discuss plan, including anesthetic plan ABCD; optimize patient condition and positioning for the pre-oxygenation. For personal protection, minimize your exposure. Use proper PPE kits, aerosol barrier. To anticipate our needs, keep ready airway equipments, airway adjuncts, working suction, required drugs, and equipments for IV access, fluid infusion, blood, whatever required for the surgery. Follow the proper intubation and extubation strategies to avoid minimal aerosol generation, like pre-oxygenate with two-hand technique, tight seal with low flow oxygen. Avoid bag and mask ventilation unless patient is hypoxic. Inflate the endotracheal tube before ventilating and avoid unnecessary disconnection of the circuit. Confirm ET tube placement with capnography or bilateral chest expansion. Minimize cuffing at intubation and extubation and avoid excessive or over suctioning, which can create cough and produce aerosol contamination. Thank you everybody for your patience. Just I want to give one disclaimer here that this presentation and video are just one representation of universal precaution based on expert opinion and my personal experience. Be aware it may differ from your institutional or local health authority guidelines. Best practices in managing COVID-19 are changing as we learn more about the viruses. Thank you everybody.
Thank you, Dr. Poman.
Yes, sir. Any question?
हॅलो सर, प्रदीप बोलतोय.
Yeah. हाँ.
सर, बॉईल्स मशीन वर कसं
नाही.
ओपन बॉईल मशीन वर घेता येईल
If
का?
नाही,
Contraindicated आहे.
if you are working without workstation, old boils machine, then you have to use one viral filter over the endotracheal tube, but still it is very risky.
Okay.
Old anesthesia machines are very risky for such patients.
Okay. To better way to avoid
Yes.
that cases on
Or
the
you
machine.
can use a viral filter in between, but still it is risky. I think so.
Okay, sir. Thank you, sir. Okay, nice presentation, sir.
Thank you.
Hello.
Yes.
Hello.
हा सर बोला, येतोय आवाज.
येतोय आवाज.
Yes.
अच्छा, routine. If you are suspecting patient is COVID
Yes.
positive or in incubation period, then you are going to use two filters. One is at the end of endotracheal tube, and one is attached to your bowel machines.
Yes.
Yes.
In positive patient also, in suspected patient also, until we found the drug, it is advisable to use two filters, one at expiratory limb and one over the face mask. And in pediatric patient, hello. आवाज येत नाही सर.
येतोय. Yes, we can listen. Yes, we can listen.
Yes, and in pediatric patient, it is recommended to use a single filter at the expiratory limb. The pediatric patient whose weight is less than 20 kg use the single filter at the expiratory limb. And filter are now so cheap, 99 rupees per filter. So anyone can afford.
Best presentation.
Any question, answer? Open for discussion.
Hello.
Yes.
Deepak.
Ha, boss.
Any specific drug that can prevent coughing in
Lidocaine.
period?
Xylocard. IV Xylocard.
Okay.
We use routinely IV Xylocard and low dose opioids like fentanyl 50 microgram before extubation and proper antiemetic prophylaxis.
And to prevent some coughing reaction, you can also recommend 10% Xylocaine spray also.
Yes. When spray can be used.
Is it possible?
Yes, possible. When patient is in deep anesthesia. Yes. The patient is in deep anesthesia, then only you can use. Once patient start awaking, you cannot use the spray. It will create more coughing and aerosolization. Fiber optic.
Patient is
yes.
COVID positive.
Yes.
So what should be the better choice in regard to anesthesia? Regional,
always. There is always regional. Whenever there is a possibility that we can perform this case under regional anesthesia or regional block, go for regional, because in general anesthesia, anesthetists at all higher risk of intubation, because intubation and extubation are the aerosol generating procedures. We can avoid such events. And even you are using regional anesthesia, use all protections, because we are not sure that patient might land up in trouble. You require to intubate him at any time during the procedure. Always keep all precautions.
What about use of hydrocortisone?
Yeah, I am not talking about the treatment plan of the COVID patient. I am here to discuss about
that treatment plan.
Yeah.
Just some people use dexamethasone.
Yes.
Like drug.
I do use dexamethasone regularly in GA patient to avoid post-operative laryngeal edema, surgical stress. Yes. That's why you can use the dexa, no issue.
For single dose, there will be no effect on post-operative treatment guidelines.
No, you can use. You can use, definitely.
Because for COVID treatment, it is recommended that
yes,
steroids should be avoided.
Yeah, like a single shot dexa 8 mg can be used. I think so.
Very nice presentation.
Yeah.
Thanks.
While you are using your suction machine
Mhm.
after the extubation patient,
Yes.
whether that suction machine is also connected to some sodium hypo
Yes.
solution bag
Yes.
or ICD bag, whether
Yes.
you are taking that precaution or not, I think it is not mentioned. What is
Yeah.
your opinion?
Yes. If you are going to use the suction, do the suction under plastic drape to prevent aerosolization dispersal. Or if you are going to use suction, keep the water with sodium hypochlorite in suction bottles.
Like ICD bags. Okay.
Yes, yes. Like I said, about what people are doing now in laparoscopic surgery, that they are dedicated single port of outlet CO2 and all the exhaled CO2, that pneumoperitonize CO2 land up in that ICD bag with a 1% sodium hypochlorite. Same thing can be applied for the suction machine also.
Whether you are using some additional drug post extubation to avoid secretions and to avoid use of suction machine.
No, in pre-medication, we are routinely using the glycopyrrolate based anti-seolog effect. So if you are using to glycopyrrolate, there is no need to use another drug for the secretion purpose. And if you think there is
Just
a
to
post
take care.
secretion, if you think there is a secretion in the post-op period also, you can repeat the glycopyrrolate, no issue.
Yes, yes. That's why I am asking about. Good presentation.
Thank you.
Hello,
Thank you.
Deepak.
Yes, sir.
Deepak.
Yes, boss.
What about respirator
Boss, we
in
are.
presence instead of N95?
Which respirator you are talking about, boss? Powered air purifier respirator, PAPR?
Yeah, respirator. Yeah, in
PAPR was to a costly 1.5 lakh price, and we can't afford. So it's better to use N90. We are using here N95 mask, surgical mask over N95 mask, and face shield. Yes?
Yeah.
Voice is not clear, boss.
Yeah.
What we are using here,
Network problem.
What we are using, we use the N95 mask. Over that, we apply the surgical mask.
About this respirator, you know about?
No, which respirator? You are talking about power air purifier, PAPR.
Yeah, this one is 3M6003.
No, I don't have any idea about that. Which respirator you are talking?
In screen, see in my face. In the screen, you see in my face.
No, boss, I don't have any idea about that. Yes, I have seen that, but I don't have any idea. We are not using. I have not seen anyone with this respirator, at least in my setup.
Okay. Okay. Thank you.
Okay.
Anybody have idea about this respirator?
It is not visualized ideally whether hello, picture is not seen clearly of your respirator. That's why I unable to tell you.
Yeah, I will say. Not our background.
Boss, Moria boss, you can share your photo or video so that everybody can see.
Okay. But wait few minutes. Yeah, this one. This is the nose piece.
Yes, I am using this. This is a kind of face mask with respirator. This gives extra protection and it can be reusable and it will be it will work up to 1 month. If it is autoclavable also, this is very good but costly. 4,000 to 5,000 approximately total cost.
No, in 3,000 was.
3,000. Yes, price can be reduced.
Boss,
but it is more safer, but you have to change your
yes.
cartridge.
You have to change cartridge in between, I think.
Yes. Yes. This is best. No problem.
Okay.
Okay.
Yes, yes, was
Thank
visible.
Yeah. Nice presentation, Deepak.
Thank you, boss.
Conclusion. Thank you.
Okay.
पांडे बॉस कहाँ गए?
I think
OT
there
में
are
गए.
many surgeons in this meeting. There
Yeah.
are recent. Anybody have the recent guidelines regarding laparoscopic surgery? Whether surgeon can perform laparoscopic surgery or not? Any recent guidelines? Dhanraj sir,
Uh,
do you have any idea?
Specifically, we are thinking of and we are planning about
Yes.
the suspected or patient in incubation period only. Those are guidelines for the same thing. Okay, just do RT-PCR if you are suspecting some HRCT thorax, and rest of the investigations are mandatory. Just we have to take precaution about two things. As per anesthesia team and surgical team, you have discussed a lot regarding anesthesia. Just I had to mention two things regarding surgically. If you are going to perform laparoscopic surgery, you have to take care regarding first port insertion.
Yes.
First port insertion, that is entry.
Yes.
Probably it should be, or you should try with minimum exposure. That is, it should be very entry one first.
Yes.
Then if you are going to do some by open technique, then the skin incision should be less than 8 millimeter size.
Yes.
Less than 8 centimeter size, 8 millimeter size, sorry.
8
So
millimeter.
that first stroker of 10 size should be snugly fit, so that the after pneumoperitoniization, the aerosol or some air which is coming out or which can come from peritrochar side, it should be avoided first.
Yes, yes.
First thing.
Peritrochar leaking should be
Then,
avoided.
yes,
Yes, yes.
there is for laparoscopic procedures there should be always put one additional port of 5 millimeter, which is to be used for smoke evacuation, or it should be connected suction tubing which is connected to your sodium hypochlorite solution.
बता दो.
Solution. Then restrict the use of pottery.
Yes,
Probably you have to use bipolar or some superior gadgets for it.
yes.
Then at the end of procedure, you have to reduce total pneumo by evacuating the air inside the abdomen through the tubing which is connected to sodium hypochlorite solution bottle or some bag.
Yes.
And then after evacuation total air, then go for closure as early as possible.
Yes. Some people also recommend that you should extract the remove the specimen after complete deflating the stomach. Is it possible or
Yes, no, it is not possible. Probably you have to use some endobag technique.
yes,
because if you are removing this specimen through 10 port or some enlargement of 10 millimeter port, then while doing some rotating or rotational movements to remove that specimen, there is always leakage of aerosols, which will be some hazardous for you, your patient, your staff, and so many things are there. So if you are going to put some drain inside, before to remove or retrieval of specimen, you have to put drain, connect to sodium hypo bag, and then at the end you have to remove specimen and go earlier for closure.
Yes, yes. Pandey boss, are you there? PS Pandey boss.
Hello.
Hello.
Hello. Can you hear me?
Yes.
Deepak.
Yes,
Yes,
boss.
yes, sir.
Yes. We can hear you.
Yes.
Deepak.
हाँ, yes, sir. बोलिए.
Dhanraj has given very good explanation about the aerosols.
Yes.
Also, we are associated very closely. We meet daily. So we had discussed one point, which this is a good webinar where we can also decide and other colleagues can also ponder over it. Once we decided that if the surgical procedure is going to get prolonged for more than 2 hours or 3 hours, in the recent guidelines, they have decided that you should have 2 surgeons.
Yes.
One operating at a stretch for at least 45 minutes and the other person taking it over for closure or something, so that the surgeon will be less exposed for a bigger time.
Yes.
So take care that the surgeries get over, if at all it is laparoscopy or even if it being any open procedure or anything, so that the case gets over within a period of some 1 hour or anything. But if the case is going to get prolonged, they advocate that it's better you keep 2 surgeons so that they keep on rotating and none of the person is exposed for more than 45 minutes.
Yes. Anesthetic should also be changed. I think so.
The point which Dr. Nitin Nalade had explained nicely, that means your exposure to patient should be minimum.
Minimized.
The ICMR guidelines are going to tell you, if you are going, if you are in contact of suspected patient, when there are maximum chances to get infected, that time period has from minimum 30 minutes to 45 minutes. So as per possible, finish your procedure within the said time period.
Yes.
To minimize the rate of infection.
Yes. Yes, Pandey boss, any comments?
Thank you, Dipak. You have presented very well, and every topic has been, I think, covered. Nothing has been left.
Anything
If anyone wants to give his any expert opinion in this COVID period, any mishappening
or boss, your voice is not clear.
So he may
voice is
Poman,
not there.
can we use introducing this endotracheal tube?
बॉस आपकी आवाज नहीं आ रही आपकी क्लियर, ब्रेक हो रही है बीच बीच में.
दीपक आवाज आ रही है मेरी?
हाँ हाँ बॉस बोलिए.
मेरी
हाँ आ रही, लेकिन बीच बीच में जा रही आवाज बॉस.
अभी आ रही है ना. मैं ये कह रहा था,
हाँ
जब हम एंडोट्रेकियल ट्यूब इंट्यूबेट करते हैं इस समय, तो हम जो हिपा फिल्टर इंस्टॉल करके उसको इंट्रोड्यूस
कर सकते हैं बॉस, लेकिन उसमें हम लोग भुगी नहीं यूज कर सकते, स्टिलेट नहीं यूज कर सकते. अगर एयरवे मालम पट्टी 1 है तो वी कैन यूज डायरेक्ट ट्यूब विथ हेपा फिल्टर ऑन इट. अगर फिल्टर बीच में लगाएंगे ट्यूब के ऊपर, कनेक्टर के ऊपर, तो भूगी के ऊपर हम लोग उसको रोल ओवर नहीं कर सकते या स्टिलेट नहीं डाल सकते अंदर. आपको विदाउट एनी इंट्रोड्यूसर ट्यूब डायरेक्ट डालना पड़ेगा.
The aerosol exposure will be high at that time.
हाँ, इंट्यूबेशन के टाइम पे रहेगा हायर, लेकिन अगर पेशेंट पूरा पैरालाइज है, न्यूरोमस्कुलर ब्लॉकिंग पूरा एक्शन हुआ है, तो देयर विल बी नो ब्रीदिंग, इंस्पिरेशन एक्सपिरेशन. So if you are confident,
difficult intubation.
Difficult intubation में you have to use video laryngoscope, stilate, boogie और introducer. वो तो करना ही पड़ेगा, यूज करना पड़ेगा. Fiber optic laryngoscope. Yes, boss.
So you want to conclude?
Yeah. Boss, agar if everything is satisfied, everyone is satisfied, we can end up the session.
Yes, thank you very much.
Yes.
You have very nicely presented this topic.
Yes.
And I think we have done for the first time so nicely. So I want to welcome all the delegates, friends and doctors from Pune also. We are all from Varanasi, welcome you all.
I
So
think
thank you.
yes, next session will be from surgeon side, I think. Any of
Yes. This will be, I think, good.
Yes.
So we can conclude or close this session.
Yes, yes, boss. Yes.
Okay.
Yes,
Thank you. Thank you, Dipak.
Thank you, everybody. Thank you.